Okay, great. Hello, everybody, and thank you for joining today's listening session for Medicare Shared Savings Program Accountable Care Organizations. During today's presentation, CMS will seek feedback from Medicare Shared Savings Program ACOs on the Alternative Payment Model Performance Pathway, or the APP. Please note today's session is being recorded. The slide deck recording and transcript will be posted to the QPP webinar library in the next week for further review. So now I will turn it over to John Pallott, the Director of the Performance-Based Payment Policy Group within the Center for Medicare, to begin. John?
Thank you, Lauren, and thank you all for taking time out to join us today. We look forward to hearing your important feedback regarding the new quality reporting requirements, specifically the APM performance pathway for Medicare Shared Savings Program ACOs that we finalized in last year's Medicare Physician Fee Schedule rule. We appreciate you taking time out of your day to provide us feedback, and we appreciate the feedback we've received to date from stakeholders. Today we have several targeted questions we are seeking your input on, but we welcome comments on other areas as well. I would point out we are in listening mode only, so we will not be responding to questions. However, we will take all the feedback that we receive today, and as well as feedback we've received so far to date under advisement and consideration for any future changes to the quality reporting requirements under the Shared Savings Program. Again, thank you for joining us today, and I'm pleased to introduce our colleague, Dr. Michelle Schreiber, who is the Deputy Director for Quality and Value in the Centers for Clinical Standards and Quality at CMS.
Thank you, John. I appreciate it. In addition to the Deputy Director of the Center for Clinical Standards and Quality, I'm also the Group Director for the Quality Measures and Value-Based Incentives Group responsible for the traditional Mips program. I too would like to join in welcoming you to today's listening session and to assure everybody that your comments and feedback are really very important, and we do take them into consideration when it comes to rule writing and designing our programs. There are several other key staff on the phone today from the Mips program who will be listening in as well as a little bit later in the session, we'll be joined by Dr. Lee Fleischer, who is the Chief Medical Officer of CMS and the Director of the Center for Clinical Standards and Quality. So again, thank you to all for taking your time out to be with us today. Let me pass then to Stephen Johnson to begin today's session. Thank you.
All right, thank you, Dr. Schreiber. Thank you, John. As provided earlier, this listening session is current, or this listening session is current at the time it was published or uploaded onto the web. This is our normal disclaimer. We'll go ahead and go to the next slide. So I want to give a little bit of background before we start the listening session to make sure we're all on the same page. So the Alternative Payment Model Performance Pathway, APP, is a reporting and scoring pathway for merit-based incentive payment system eligible clinicians who participate in Mips APMs. It is required for all shared saving program ACOs, and it focuses on patient outcomes, reducing the number of measures ACOs report, and aligns the shared savings program quality reporting requirements with the requirements under the quality payment program. Next slide. The quality reporting requirements under the shared saving program align with the requirements that will apply for the APP under Mips. For performance year 2021 only, ACOs can choose to report 10 CMS web interface measures or 3 electronic clinical quality measures, ECQM, Mips, clinical quality measures, Cqms, and administer the consumer assessment of healthcare providers and systems, the Capture Mips survey, and we will calculate 2 administrative claims-based measures. For performance year 2022 and subsequent years, ACOs will be required to report 3 ECQM Mips Cqms and administer the Capture Mips survey. Additionally, we will calculate 2 administrative claims-based measures. Next slide. So we just want to get on right into the discussion. We will, like I provided earlier, we have a list of questions that we are looking to receive feedback on. And so we will start with going to our first question. Next slide. And I will turn it over to Ketchum.
Great, thank you, Steve. Just a few reminders before we begin. During today's discussion, you will be able to submit comments at any time via the chat box on your GoTo menu, and we will read them aloud. We will also be accepting phone feedback. So to make a comment over the phone line, please raise your hand. You can do this by toggling the green hand icon on your GoTo menu, and we will unmute your line. If you are dialed in by phone, please note that you must have your audio PIN entered to speak. For those using computer audio, you must have a working microphone. Again, as a reminder, everything will be posted to the QPP webinar library in the next week, and we will share that link to the webpage in the chat box shortly. So with that, Steve, we will turn it back to you to begin today's discussion.
All right, great. Thank you, Lauren. So the first questions that we have are around the reporting requirements. What challenges does your ACO face in reporting the APM performance pathway, APP? And what can we do to promote ACO's successful transition from reporting through the web interface to reporting through the APP?
Okay, looks like we have a few people interested in the phone line. So Adrian Gerlash, we will go ahead and unmute your line. Adrian, you may go ahead.
Thank you. My name is Adrian Gerlach. I'm from Connected Care of Southeastern Massachusetts. And one of the things we've been struggling most with is around this requirement that 70% of patients that we have to report on them, no matter the payer. So like other ACOs, we have a mix of primary care and specialty care providers. We don't have access to all of their patient information. We have access to the beneficiaries electronically. So one of my main questions is, I'm not sure how we can ask practices for data on all of their patients that aren't beneficiaries. We have no really authority to do that. Can you talk a little bit more about the 70% rule and how that actually works?
Thank you. So on the call today, we definitely appreciate that question. We do plan to submit and provide more guidance later in the summer. But today's call, we really are focusing on these questions and getting feedback from you all as far as what specific challenges you're facing. I see one that you talked about is the 10% of patients, including all payer populations, and the fact that and the concerns that you have regarding the fact that you don't have access to these patients, or potential, other agreements that are in place don't allow for the sharing of that patient data. So, I think that's definitely noting that. But if they are, I think, again, we're going to note your challenge. But on today's call, we really want to focus on receiving all of your feedback. So thank you for providing that feedback, though.
Okay, I hear what you're saying, but I want to express that that's probably a very real challenge for, I would imagine, most ACOs on this call, understanding the 70% requirement and what that actually means. And if an ACO doesn't have access to a practice's entire patient panel, how would we get Medicare that information?
Definitely understand and note it. Thank you.
Okay, great. Next, we will take a comment from Joseph Bartman. Joseph, we are unmuting your line, and you may go ahead.
Hi, can you hear me okay?
Yes, we can.
Thank you. So one of my questions is related to, we have a large national ACO with many employed and independent providers, and certainly many of us operate on different EHRs as it is today. Most of them, have the 2015 cert requirement and the ability to produce data files, but certainly with a large number of disparate EHRs, just curious for your thoughts and how we are working to make sure all the information is gathered. And certainly it's a incredibly large lift for us to make sure that, we get all this information. One, that the workflows are all in place in the correct order on all these different EHRs, so that it's reported correctly through the performance year. But then additionally, collecting all that data, it's quite a large lift for us, and I know that other organizations express the same concern.
Thank you very much, Joseph, for that feedback. Yeah, we have been receiving a lot of feedback regarding the large ACOs that have many disparate EHR systems and trying to calibrate the various workflows in place in order to make sure that they're reporting to CMS. So, this challenge is definitely noted, and, that's something that we will continue to take under advisement. Thanks, Joseph.
Okay, great, thank you. Next, we will take comment from Amy Allred. Amy, we are unmuting your line, and you may go ahead.
Hi, just had a real quick question about clients that we have that may be transitioning to a new EMR in the middle of the year. As an ACO, I understand that we're responsible for aggregating all that data, and my concern is if they're not going to port over and migrate historical data to the new EMR, everything's going to live in two places. And so we would have to produce, I'm assuming, Ecqms out of the old system, which is probably going to be in some type of repository, as well as the new system. And for a lot of the measures, such as, say, the blood pressure measure, where you're going to have to extract the last BP that's available, that would produce duplicates in the denominators and possibly the numerators as well. And just wanted to see if there's any thought about how to address those types of situations, which are going to be common.
Hi, Amy. Thank you very much. I do know that we've continued to hear concerns regarding how to take out the duplicates in reporting to CMS. Just to note that this is obviously aggregated data that we will get. But again, your question is noted, or I'll just say your challenge is noted. And that's something that we'll continue to take under advisement and look to figure out how to provide additional support.
Hey, thank you so much.
Thanks, Amy.
Okay, great. Flitting back to the chat box, we did want to note we are seeing a few comments that data aggregation is proving to be a challenge. One notes that our ACO currently includes a range of groups that span over 23 different EHRs, and aggregating data for all payers for these providers is incredibly challenging. There are other comments on the timeline as well. One commenter noted that we are an ACO that has multiple practices on multiple EMRs, and we feel as though the timelines to fully transition to the APP is too limited.
Well, thanks, Lauren. I want to definitely see if there are any ACOs who have any suggestions on how we can promote ACOs to successfully transition to report, take into account, all of the feedback you guys have been providing to date regarding, the 70% of patients, which includes third-party payers, the different EHR systems, if migrating from an old system to a new system. What would you suggest for CMS? What can CMS do to promote a successful transition to reporting the APP? If there are any suggestions, we definitely will have to talk about that now as we transition.
Okay, we'll take a comment from Kathy Johnson. Kathy, we are unmuting your line. And if you'd like to unmute on your end, you may go ahead.
Great. In that vein, one of the challenges is that FHIR is not yet available or required. That would definitely make the transition much easier. From what I understand with our technical folks, I represent several ACOs, again, multiple EMRs, and in fact some paper practices. So if we look at the Ecqms, we don't have any central visibility into performance. It would be directly from that EMR into CMS. So we're forced to use a qualified registry, which is obviously an added expense. And it's something that when you look at the statistics on how the quality scores tend to drop when you go from the web interface to Ecqm Actually, Mips CQM, it's lower, and then ECQM is even lower than that. I was wondering if there's going to be any benchmark changes, and are the benchmarks going to be based on how it's submitted? And I know you're not answering any questions. I'm just putting these questions out there. I also have a question, and I do find it very difficult to find information on this subject. Part of the problem is the terminology. Whenever you go to QPP or CMS and you start searching on ECQMs or APP, they're just, ECQM has multiple definitions. Not only is it a submission approach, it's also an actual measure itself. So a clarifying way for the ACO to have information would definitely help us be more successful. But
Thank you, Kathy. I'm not sure if you continue. I'm not sure if you got cut off, but we definitely will take under advisement as far as, you know, your last statement of clarifying kind of where ACOs can find more information about the ATP and what is pertinent to them, as well as, you know, understanding that the FHIR requirement that's not yet required would also make transitioning to the APP reporting much easier. So thank you very much for your comments and your questions. And, you know, we again, like I said, like I'm continuing to say, we're definitely taking this under advisement and take this back to figure out how we can provide better support over the performance year. So thank you very much, Kathy.
Okay, great. Again, from the chat box, we are seeing a few recommendations such as limit reporting to ACO assigned patients only, further support by extending or not making mandatory ECQM submission, and again, providing more of a buffer within timelines if possible. So Stephen, with that, I think we will move on to the next question in the interest of time.
All right, awesome. Thanks, Lauren. So the next question we have is regarding potential ATP modifications. Similarly to the first question, a couple questions that we asked, how can CMS improve the ATP, such as expanding the Mips quality measures that ACOs could report? This is specific for shared saving program ACOs.
Okay, great. We will first take a comment from Jason Shopsher. So Jason, we are unmuting your line and you may go ahead.
Hi, can you hear me?
Yes, we can.
Yes.
Hey, thank you. So just I echo basically what everyone said, especially the first person regarding the need for definitive clarification regarding the 70% data threshold, because I've called and searched multiple times and gotten different answers from QPP versus CMS versus MSSP sources. So that would be very helpful to get a detailed clarification. But just to expand on a couple of other things, it's very hard when you're representing a network of small independent practices who are going to have to incur the cost of aggregating this data. Even though they may be CERT qualified, they're not building these measures and their EHRs are going to charge them to do so. So I know CMS is interested on ways to help small practices. Well, this is a huge burden and cost to do to them, especially during the time of a pandemic. So I have that comment, and ways that they can improve. I certainly would recommend potentially limiting, again, the beneficiary data to ACO patients only, or at least just Medicare, doing a stair-stepped approach. And similar to Mips, there ought to be some sort of exemption if you're a small practice with less than 5 docs or something. You don't have to submit ECQM data because, again, the cost to do so is just not, it doesn't make sense. So that's my suggestion. To your most recent question, there should definitely be a set of measures, more than just 3 automated measures. There ought to be a set of at least 10 or so where you can choose 3 of those 10 to report versus you have no choice in which to report. Thank you.
All right, great. Thank you, Jason.
Okay, great. Next, we will hear from Anne-Marie Starrett. Anne-Marie, your line is unmuted and you may go ahead. Anne-Marie, if you'd like to unmute on your line, you may go ahead.
Hi, I don't necessarily agree with Jason in that increasing the measures would be helpful, other than if you have specialists in your ACO that they wouldn't have to report on the 3 required measures. And I'm wondering when we'll get further information as to exactly how the aggregation is going to work. For instance, if the members in multiple EMRs, when you aggregate that data, is it an aggregation based on score per EMR per measure, or is it an aggregation based on each, like, performance for every member? So if I'm a member and I'm in multiple EMRs, am I in the denominator on every EMR, or does the aggregation bring it down to just my last blood pressure, regardless of which EMR I'm in? So there's no information at all on, when we pull this data, how it's aggregated. And at the same time, if I'm in a specialist EMR and I do have diabetes and I do have hypertension, and there is a depression screen that's required, if it's a foot doctor, there's no chance that any one of those things would happen. However, he could have the diagnosis for hypertension in the medical record. He could have the diagnosis for diabetes in the medical record. And because I had a visit, I would be eligible for a depression screen. But an orthopedic or a foot doctor is not going to do any one of those things. So, like, where's the information on that?
All right, thanks, Anne-Marie. More guidance will be coming out regarding data aggregation soon. But we definitely appreciate the feedback that you provided.
Okay, great. A few comments that came in through the chat box include do away completely with reporting Qms and use claims-based calculations of key metrics. Another says the scope of reporting is too broad to be able to perform well, so limit reporting to primary care, Medicare patients, and create an exception for small practices. So we will go back to the phone line and we will hear from Susan Merrill. Susan, we are unmuting your line and you may go ahead.
Thank you. Can you hear me?
Yes, we can.
Okay. Thank you. Actually, I'd raised my hand for a previous question. I wanted to make a point that I'm part of Common Spirit Health. We have 12 ACOs, and there's a lot of consideration about dropping specialty practices and possibly some of our independents because of the 70% or 100% reporting requirement. And I wanted to make the point that if we're trying, or CMS is trying to get more participants into value-based programs and moving toward capitation, we need to have fewer onerous requirements. Otherwise, we're going to have to drop different kinds of providers to be able to meet reporting requirements, and that really doesn't seem right. Thank you.
Okay, great. Thanks for that feedback, Susan.
Okay, great. All right, again, further recommendations from the chat box include delaying ECQM reporting requirements for about 3 years, develop promoting interoperability requirements for EHR vendors to implement and launch with their clients. There's a suggestion if participating TINs could each submit their own EHR systems ECQM data and CMS combine the data for SSP on the back end, or send ECQM data for SSP attributed patients. I believe that got cut off. Great, so quite a lot coming into the chat box. But again, in the interest of time, we will move on to the next question and pass it back to you, Stephen.
All right, great, thank you. The next question we have is around interoperability. How can we incentivize ACOs to use of a fully integrated interoperable health information exchange infrastructure? We definitely have, heard some of the feedback that was in the chat room about delaying the requirements for 3 years or developing more appropriate requirements specific for ACOs. So any, feedback, any suggestions on, how we can, get ACOs to fully integrate their EHRs, we definitely appreciate that feedback.
Okay, great. So first we will hear from Leslie Alabi. Leslie, we'll go ahead and unmute your line, and you may go ahead. Leslie Kalaman Alabi, we've unmuted your line. If you'd like to unmute, you may go ahead.
I'm sorry, can you hear me?
Yes, we can.
Okay, I actually had a comment that I threw into the chat box a bit earlier, so I apologize for the inconvenience. I'll pass to the next person.
Of course, no problem. We actually did just get a few comments in that include provide reimbursement for expenditures related to building and maintaining the HIE, provide credit for purchasing an analytics tool to integrate across all EHRs, or subsidize the cost as it is incredibly expensive to move 55 independent practices to a common EMR. So we'll go back to the phone line. Chuck Kanzerski, we'll go ahead and unmute your line. And Chuck, you may go ahead.
Okay. Chuck Kanzerski, I'm Clinicians Health. We're a qualified registry and are working with several ACOs on 2022 submissions. So aggregating the data, we understand the requirements for that, but some thoughts on the program overall. That it's come up, how do you handle specialists? A suggestion along those lines is to limit the patient population that you're looking at to primary care patients. So, if they are only seeing a specialist in the ACO, that they wouldn't be considered part of the 100% would be one way to address that. I think, the other thing that's really kind of hanging out there for everybody, all of our customers, as well as the qualified registries, is that we're 5 months into the year now, going into the 6th month, and there's still guidance that's forthcoming. We don't know exactly when. We're working through some proof of concepts with existing ACOs on how we think it's going to work, but depending on what that guidance is, we're going to have the second half of the year to deal with this. So one thought would be to, rather than making a complete switch in 2022, to make it a proof of concept year for everybody, still use the web interface for primary reporting, but have part of their quality score based on maybe doing one practice or some subset of patients. Maybe it's not 70%, but show that you can do it. You can do this kind of reporting, but not expect 70% of your total population to do that. And then the other thing I think that the previous caller mentioned, since this is going to be an additional cost for the ACOs, to somehow subsidize it, whether that's a flat rate based on the size of the ACO or the population, or some kind of increased percentage of earnings on shared savings. Some way to subsidize the cost, because this is an unexpected cost, when they signed up for the program, and is causing them to have to reevaluate, again, what an earlier caller had mentioned, dropping specialists completely. So everybody's having to rethink the program. I think it would be beneficial for everybody to kind of have some extra time to figure this out, including the people that are in charge of the program, and see what's going to work and what's not going to work. Those are my comments.
All right, awesome. Thank you very much, Chuck. Definitely have your feedback down, and very, very helpful feedback. Thank you.
Okay, great. We have time for one more comment on this slide. So Lindsay Reed, we'll go ahead and unmute your line. Lindsay, if you'd like to unmute, you may go ahead. Lindsay Reed, you may go ahead.
Sorry, I'm here. So I just wanted to comment on a couple of different things. One is I think that, which might be a little ad nauseum at this point, you know, really in my opinion and the opinion of my colleagues that I work with, if we're going to make the quality measures this way, then it should only be primary care physicians that should be responsible for reporting, as they're sort of the ones who are supposed to be, you know, maintaining that care and being the main center of that patient's care, and not have to make the specialists report, which would allow us to continue to have specialists in our organization, but doesn't restrict us on what we can and can't get from them. Additionally, you know, it's important to note, we've kind of belabored the point that this is a very costly requirement that CMS has put at the feet of our independent physicians. And respectfully, it feels like every substantive question that's being asked, we're being told, we'll get to that later, we'll have information for you later. And it feels like with the large lift and the huge expense that is now at the responsibility of the providers to manage your requirements, we should have had the full breakdown of every single piece of this requirement before we have to implement it. And with it being a year and a half before we're required to be fully reporting for you, that's really not sufficient time. And I think that pushing back the start date by a year or two to let CMS figure out what they need, to then communicate it to the providers and the organization so they can understand what they need and whether they can actually meet those requirements, would make everyone a little more comfortable with the new quality program.
All right, great. Thank you very much, Lindsay. Real feedback regarding only requiring the primary care physicians to report and not having a specialist report as well, and potentially, you know, if thought about having CMS push back the start date. Thank you very much, Lindsay.
Okay, quite a few people in the chat box agree with Lindsay's comments about not enough time to successfully implement. We've seen other recommendations that include to provide sufficient funding to states to develop fully functional health information exchanges and have them be at no cost to providers, make it mandatory for each state to allow competition between HIEs for pricing, or allow individual TINs or each unique EHR to submit data on an interim basis to CMS, who could then combine results. So we will move forward to the next slide, Steve, and pass it back to you.
All right, great. So next questions we have are, again, reporting on the Ecqms or Cqms. What is your experience with ACO participant TINs or providers or eligible clinicians reporting Ecqms or Cqms to Mips? How can that experience be used to inform ACO level reporting?
Okay, we will first hear from Chandrash Saraya. So Chandrash, we will go ahead and unmute your line. Chandrash Saraya, if you'd like to unmute, you may go ahead.
Okay, I hope you can hear me now.
Yes.
So I actually raised the hand for the previous question on the interoperability. And, you know, in terms of integration, I don't know if our ACO is fully integrated. I can say we are more integrated than we were historically. But one challenge we had on the way was getting cooperation from the institutions, local hospitals, opening up to the HIE and make it available to us for our patients. So we ended up having to subscribe to a service, and it's a pretty expensive service. And we currently have it for limited number of patients. There is a need for us to do it for all our patients. But then the cost factor does come in, like others have pointed out. So my question to you is, are we requiring the hospitals and other institutions to make it easy for the HIE information be available to the community physicians? And if we don't have that, would we consider doing something like that, so that it becomes, you know, easy for the community physicians? Thank you.
Thank you very much, Andra. It's very, very helpful feedback and some thoughts that we'll definitely take back around requiring hospitals to, really share their health information and kind of really to improve the health information exchange. So definitely gonna take that feedback back. So thank you.
Okay, seeing varying responses in the chat box. One notes that our specialists have taken advantage of QP status for many years. They have been excluded from Mips and have little experience reporting. Another notes the medical group for 2 of our ACO participant TINs has experience reporting Ecqms for CPC and CPC+. 2 participant TINs have no experience with Ecqm or CQM to Mips. Another notes that as an SSP, we have 0 experience to date submitting Ecqms or CQMs to Mips. We only submit Ecqms to CMS for the inpatient hospital setting with success. So we'll go back to the phone line and hear from Michelle Brown. Michelle Brown, we will unmute your line and you may go ahead.
Yes, hi, good afternoon. Can you hear me?
Yes, we can.
Okay, great. So I share, most every single comment that's been shared right now, and I'm certainly not of the mindset that we should be putting a lot of our vendors, out of business. But I think that for our ACO, we have 10 different tax IDs. We actually do have an enterprise data warehouse. It's basically taken us over 8 years to really get it functional to a level, and largely because of some of the other comments about it's cost prohibitive in many ways because of the expenditures that we have to account to our vendors. With every time there's sort of a change underway, and in this case, a change that's not been made very clear. And a lot of our participant organizations are predominantly FQHCs, and so they're under, they've not necessarily been held to all of the same quality reporting requirements under Mips as non-FQHCs. I particularly appreciated the comment about the proof of concept idea, but we have been evaluated for quality with our MA payers for years. And under the mindset of convergence, I'm wondering why some of our organizations that actually have been evaluated for many, many years under quality standards that are very similar to the ones that were being held to by CMS for traditional beneficiaries in a very stringent way. We report out on, like I said, many of the same measures. Some of the claims-based measures obviously roll into our objectives toward value-based reimbursement and in earning gain share, under other books of business. And if we get those reports, why couldn't they serve as an attestation to our performance? If an organization is performing at a 4-star level across, let's say an equal amount of Medicare attributables, then why couldn't that serve as some sort of representative, even an inner performance measure, until some of this work around getting EHR vendors to converge on this, getting data warehouses to be able to accommodate being nimble in being able to report, because you can get everything ready, but again, the terms of our reimbursement programs are changing. It's not just quality. It's the fact that those of us in the MSSP, we're evaluating direct contract opportunities. Those programs are being pushed and pulled. So it's not necessarily the quality that rolls into this reporting requirement, obviously, but it seems to me like if an organization is performing and can document their performance to be of standard or exceed the standard, that we should be able to attest to that performance. And then those that are still on that learning curve or have greater opportunities, similarly, it would at least provide their attestation would provide a baseline of where they really are. This just seems like a lot of duplication, like many of others have alluded and directly stated, and a lot of, it's kind of cart after the horse, if you will, because I really appreciate the comment that here it is June, and we don't know where to go. And we have 700 doctors in our ACO, and ultimately they're driving the bus on this. Aside from the technology, I just think maybe an attestation approach, even for a couple of years, is just my comment, my feedback.
All right. Thank you very much, Michelle. Definitely appreciate the feedback regarding potentially using another program that you all are likely already reporting to, and potentially do an attestation to the shared saving program quality portion. So definitely appreciate that feedback as well. While we're on this question, I also want to solicit feedback from others as you guys are in line for this question to think about, would it be worthwhile to report to Mips in a completely separate way, similarly to how other APMs report on Mips. So we just want to get thoughts on that as well, as you're talking about the experience you guys have with some of the TINs and ACO reporting to Mips. So just also want to add that as well as we're considering, as you guys are considering providing us feedback.
Great. And as people are responding to that in the chat box, we'll also flag a few more that came in. So commenters have noted that their hospital has experience with ECQM reporting, but none of the specialists or primary care practices have experience. Another includes a recommendation noting that this program requires integration of patient-level data across EMRs, but the current ONC certification requirements for the EMRs requires the ability to generate QRDA CATS1, which is sufficient for this reporting. You could add a certification criteria for the EMR to be able to generate a feed based on QRDA CAT1 so that end users don't have to manually export and transmit data files. All right, seeing a few more agreements with earlier commenters. Providers appreciate the QP status in the APM to negate Mips reporting. It would be ideal to focus on reporting quality at a patient level rather than focusing on reporting at the provider level. Right, I know we are getting a few more questions in, so we will continue monitoring the chat box, but Steve, we will pass it off to you to move on to the next slide as well.
All right, great. Thank you very much. So the next questions we have are focused on specialty measures. What role do specialists play in your ACO? I know there have been a lot of comments regarding specialists today. Should performance on specialty measures be incorporated into ACO scoring? What Mips measures or MVPs should be considered for incorporation into future shared saving program scoring?
Okay, we'll begin with a comment from Shelley Thalacker. Shelley, we'll go ahead and unmute your line, and you may go ahead. Okay, no worries. We will move on to a comment from Richard Pfeiffer. Richard, we will go ahead and unmute your line, and you may go ahead.
There we go. Hi, everybody. I'm Rich Pfeiffer. I'm the Chief Medical Officer of Genesis Healthcare, multi-state, and we have a large population of patients with multiple comorbidities, often at the end of life, severely affected. And my comment actually relates a little bit to specialists, but I guess I couldn't get my hand down in time. But it relates to several of the other topic areas, so I hope you'll permit me briefly to mention it. It has to do with including deceased patients in measurement, whereas previously for the Medicare Shared Savings Program, patients who died mid-year were excluded. Including deceased patients may make sense for very transactional measures that can be immediately addressed during an encounter, which is more characteristic of Mips. But for population health perspectives and measures like the Medicare Shared Savings Program ACOs, measures that include deceased patients can be problematic. And I call into question, for example, the A1C measure. That takes time to address, and it's something that we very much should be responsible for. So I'd ask that you take a good hard look at the medical appropriateness of including deceased patients for MSSP.
Thank you very much, Richard, for your comment. Thank you.
Okay, great. Next, we will hear from Joel Port. Joel, we have unmuted your line, and you may go ahead.
Yeah, hi, this is Joel Port from the Delaware Valley ACO. Hopefully you can hear me okay. And thanks for the opportunity today to respond to your questions. And I do agree with a lot of the comments that have already been said, but to just respond to your questions that are currently posted. Specialists play a very significant role at our ACO. We've taken on the lofty goal of trying to transform care in the community. So we expanded in 2018 to include any specialists that are interested, that are willing to agree to our conditions, what we call our conditions of participation in the ACO. It's reasonable, what we think are reasonable performance standards. And I respect the questions being asked about adding specialty measures or other measures, but I think fundamentally, I guess I do want to go back to web interface. Web interface focused on the patient. And it does feel with Ecqms and the measures we're talking about today, the focus is on the EMR and how good an EMR vendor is, or how the software is being used. And we're forgetting the patient. And I don't want to forget about the patient, because I think that's our opportunity to improve care in the community. So that's the question I think needs to be really focused on, is what can we do to improve care to the patient rather than seeing how good an EMR is. So thank you for the opportunity to give some comments.
Okay, awesome. Thank you very much, Joe, for that feedback as well regarding patients versus say focusing on the EHR and software. Very much noted. Thank you.
Okay, wanted to flag a few comments that are coming in through the chat box. One notes a preference to keep things simple. They don't believe that adding additional measures for specialists are necessary if other changes are made to the program around quality reporting. Another notes that specialists help coordinate care and direct back to the PCP. We work on decreasing duplicative imaging. Specialty performance measures, in addition to PCP measures, will only add to the lift of combining the data and monitoring quality to improve it. Okay, so I think our last comments on this slide can come from Maureen Mayu. Maureen, we'll go ahead and unmute your line now.
Hello, very quick comment. But I posted earlier that I think we really need to do away completely with reporting for one reason only. ACOs by default already stepped up to the plate and said, yes, we will take the risk and we will improve these patients' performance and experience. I think it would be a good gesture from CMS to say, yes, we'll go ahead and do quality reporting based on claims data only, and we will not burden you with reporting extra data. I think that would, I know it sounds extreme to you all, but I really think that would be a good step forward into giving ACOs more incentives and understanding that there's cost associated with this quality reporting, and they don't have to be burdened with it. Thanks.
All right, great. Thank you very much, Maurice. Definitely noted regarding your support for requiring claims-based data only instead of EHR reporting. Thank you very much.
Okay, great. A few more are quickly coming into the comment box saying MSSP was designed to place overall care accountability on PCPs. Any quality reporting requirement for a Medicare Shared Saving Program ACOs should be limited only for primary care. Another note that they've tried to engage specialists in regards to the cost of care to reduce preventable admissions and readmissions and ED visits. And many agree with Maureen's, our last caller's comments about patient focus. So I know we are running close to time and can look to stay on a little bit longer to keep getting through these slides, but Steve, we will pass it on to you to move on to the next question.
All right, great. Thank you, Lauren. The next question we have for you all is, what other considerations should we take into account in improving healthcare outcomes? You guys have provided us a lot of really good feedback today. So right now, I just want to look into what other considerations should we consider for the shared savings program ACOs.
Okay, we will first hear from Lori Teach. Lori, we've gone ahead and unmuted your line. You may go ahead.
Hi, thank you. Just a quick comment, because actually I think this is a really good question to ask, and I appreciate it, because one of the first things that I would recommend is when you look at all of the different CMS programs, it seems like each one of the programs has this slightly different flavor in terms of what's being monitored or what is brought to the forefront as to how ACOs or how organizations are graded or how they are assessed. And I would say to help us improve healthcare outcomes, if across the board, if we had similar objectives across all CMS programs, that would allow institutions to appropriately strategize to try and improve those particular outcomes. But when you have 3 areas that we're asked to look at for one program, but then maybe 2 other measures for another program, it becomes very difficult for organizations to be able to prioritize and be able to affect change. And so I think that if across the programs we could standardize the goals, it would be, I think that would allow us to show positive movement in those areas. Thank you.
All right, great. Thank you so much, Lori. That's actually we'll feedback to you as well. Is figuring out, how can we align all the quality programs to CMS. With that, as folks are looking at this question as well, can folks also think about what recommendations do we have that do ACOs have to not disadvantage healthcare providers? ACOs that serve vulnerable population, and really working towards health equity. So as you guys are thinking about this question, to also think about if you can provide suggestions on how we could provide better advantages to certain vulnerable populations.
Okay, great. And just to flag a few that came in before the focus on equity, a few mentioned to make sure benchmarks are clear and provided in advance, restore the opportunity to earn bonus points for quality reporting, as bonus points were incentives to go the extra mile, continue to offer the web interface option until ACOs can transition to common EHR platforms for reporting, or allow multiple files to be submitted on behalf of the ACO. So I know we are getting a few more. In the meantime, we will hear from Megan Reyna. Megan, will go ahead and unmute your line, and you may go ahead.
Hi, this is Megan Reyna. I'm from Advocate Aurora Health. We have 3 MSSP ACOs. I think this is a great question to ask, and I really appreciate it. Strategy-wise, MSSP ACOs really are a cross-continuum function. So just like the commenter before me had mentioned, really making sure that CMS programs are not necessarily in competition with the ACO, but really take the ACO as working or even an opportunity to pilot some of those programs through the ACO would be really helpful. And even within quality itself, really look at how quality can be a cross-continuum effort that includes both PCPs and specialists versus looking at them as something that's competing against or is one or the other, but really looking at it as a cross-continuum effort. I think equity can also really fit in that model. ACOs and value-based healthcare in general really provide a great opportunity where you're looking at a population of patients to improve the health of those patients with equity. Definitely fits into that. I think it can be a great forum to be able to measure how we are improving and really help incentivize to drive health equity across the continuum.
Awesome, Megan. Thank you very much. In reference to your comments regarding treating ACOs as the I'll say cross continuum of care. I think that we definitely appreciate that comment, and definitely we'll take it back as well as far as ACO's place in ensuring health equity for the patient population that you all serve. Thank you very much.
Okay, great. We see a few comments to note to please take rural populations into account when when creating metrics. Another notes to please make it easy to do a voluntary assignment, as the current process is very difficult for most beneficiaries. And another just came in, notes a recommendation to consider a grant program for ACOs to utilize, which could address social determinants of health in their at-risk populations, as they are the closest to patients and can provide the care coordination that patients need, but oftentimes lack the resources to provide the assistance. So we can take one more commenter on this question before moving on, and we will hear from Jennifer Gasparini. Jennifer will go ahead and unmute your line. And Jennifer, you may go ahead.
Thank you. I'm Jennifer Gasparini with the National Association of ACOs, NACOS, and we have been communicating many of these challenges that you've heard from our ACOs today on this call. So we're really pleased that you're taking the opportunity today to hold this listening session and continue to get stakeholder input. So first, I just want to thank you for that. I won't repeat a lot of the comments that ACOs have already given you today, but I did want to add one that I feel we have received from many members that hasn't been communicated today, and that's about the benchmarks. And we really want to see CMS clarifying and establishing what the benchmarks will be for ACOs in advance of the reporting period. This is really essential for improvement activities that ACOs are focused on. Is really just, the fair thing to do for a model which places many ACOs at financial risk for not performing at a certain level. I also wanted to make a point about the guidance, the lack of guidance that we have. I know you all are facing a great challenge in trying to get this up and running, and there are many unique qualities to ACOs reporting, as you're probably learning. But with this lack of guidance at this point in the year, several commenters have mentioned that it's, already midway through the year. We just don't feel that ACOs have what they need to be successful. We also heard a vendor communicate today about their concerns with the lack of guidance. And of course, trying to get these things up and running comes at a cost, as many callers have mentioned today. And being halfway through the year, we're very concerned with the lack of guidance, and we really urge CMS to consider pushing back these requirements and delaying these requirements to give more time to really stand up the processes that ACOs will need to implement these changes. So thank you, and again, for holding this listening session, and I'd like to give the time back to the ACOs on the call today.
All right, thank you very much, Jennifer, and definitely appreciate you bringing up concern regarding the benchmarks not necessarily available, as well as regarding us providing more guidance, which we will in the very near future. But thank you very much.
Okay, great. I know we are currently at time, but we have just a few more slides to get through, and we'll continue taking comments. So to be respectful of everyone's time, we will move ahead to make sure that our final question can be asked, and we will take more comments over the phone and chat line in response to this and other questions asked earlier.
So yeah, so the our final thoughts slide. Are there any final thoughts you would like to share? Of course, we've heard a lot today regarding multiple EHRs. We've heard concerns regarding or suggestions or considerations to require only primary care physicians to report, and a plethora of other concerns that we've heard and suggestions that we're all taking under advisement. But lastly, what else would you guys like to share about transitioning to reporting via the APP? We definitely want to look to see if there's a way that we can, what should we take into consideration as this is becoming the new reporting requirement. So I will stop there.
Okay, great. And as we wait for a few more comments on this question to come in. We'll note a few more that came in between the last one. That says to improve healthcare outcomes, CMS should consider sharing applied research methodologies, share how ACOs who over time improve outcomes use data to drive actions, behaviors, and/or attitudes, especially around addressing social determinants of health to equalize healthcare. Another noted that expanding waivers to other programs can assist with equitable care. So we'll keep monitoring these. In the meantime, we will hear from Ashley Ridland. Ashley will go ahead and unmute your line, and you may go ahead.
Yes, hi, can you hear me?
Yes, we can.
Great. Hi, I just want to echo our thanks with Evolent Care Partners. We're an ACO that's currently operating in 6 states with independent physician practices. So I certainly identify with a lot of the comments that have been shared. Really grateful to you all for listening to those comments today and for holding this listening session. I know I had my hand up earlier, and I think a lot of people have already touched on my comments. I would just echo, I think the main thing for ACOs with multiple TINs, the biggest concern is the all-payer requirement. And I think there are ways to address that. Perhaps having more time, to report through the web interface. As we continue to work through some of these issues. We've also talked about EMR requirements and sort of putting more pressure and more focus on making sure that those standards meet the certified health ERT requirements. I think what we don't want to do here is we don't want to have quality measure reporting not reflecting actual quality, but reflecting more system flaws. So that is a concern. I would echo Jennifer's comments on making sure we have the benchmarks and the standards in advance, and that's critical. We are all here and we're in on performance-based risk. That's why we're part of an ACO. So I think what we want to do is make sure that we have a baseline that we can measure to and improve from. And that's really important in this program as well. I think we're all committed to improving health outcomes. And just thank you again for listening to our concerns today.
Okay, great. Thank you so much, Ashley, for your comments. Of course, and other comments that we heard regarding potentially creating benchmarks, more time to report via the web interface, and thinking about some of the EMR requirements as it relates to CERT. So that's definitely all taken under consideration. Thank you.
Great. Next, we will hear from Nicole Dorsey. Nicole, we have unmuted your line, and you may go ahead. Nicole Dorsey, your line is unmuted, and you may go ahead if you have comments.
They've been addressed already.
Okay, not a problem. We shall move on now to Jordan Hall. Jordan, we have unmuted your line, and Jordan, you may go ahead.
Hello, can you hear me okay?
Yes, we can.
Perfect. So I appreciate you guys hosting this session today. I think it's been very valuable. And I wanted to focus on things that you guys had asked about, suggestions and recommendations that could help us move forward. I think all of us ACOs that have the same issue of disparate IPA or disparate systems, the cost. But one of the things we haven't talked about is I think what would be most effective in coming up with a solution that would meet the needs of the ACOs is to go back to your ACO regional coordinators. They know the ACOs best in each region, and have CMS and the QPP as well as CMMI, who has a play in this, have smaller sessions to get actual productive feedback on what would be helpful moving forward. We participate in our learning sessions on our regional level, and it'd be helpful that if we can have this kind of same type of modality or the same method of being able to communicate to CMS and CMMI and the QPP in these smaller sessions, so you can actually get feedback from a different variety of ACOs. Most of us aren't employed ACOs that have one common EMR. And I think most of the comments you're hearing are from the frustrations and or fears of us not being able to accommodate those types of challenges with the new requirements. The cost and the administrative burden alone is what most of us are focusing on. But if we talk about solutions like a timeline or a tiered pathway to being able to implement these new quality systems is what we're looking for. Starting off with maybe your ACO attributed population and then looking at doing other Medicare-like. But we have to talk about, and what we don't hear is what the ACOs are getting that gives us access to being able to request from a disparate or a specialist, or even one of our primary care providers that's not employed, like asking for 70% of their data on commercial patients that we have no contractual relationship to. I'm going to point to the CERT EHR requirement. So those of us ACOs who've had to do the CERT audit, we've communicated these challenges multiple times, where our providers oftentimes practice in other practices, or they don't own the EMR. They're just an independent physician in that office. We've had challenges in even just being able to get the CERT documentation because we don't have a legal authority or contractual relationship to whoever who owns that EMR. Secondly, regarding like CPC Plus, for example. CPC Plus is a program where you sign on understanding it's an all payer. None of us on this call today in the ACO program knew we were signing up into a program that's going to require us to report all payer quality. We thought this was Medicare fee-for-service attributed members. This requirement to throw this in a loophole without giving us any authority to being able to do so, request this data on behalf of the providers, is a major barrier that I don't know if CMS is considered from us on the ACO's perspective. But again, I would really emphasize and encourage CMS to take this to a smaller level in our regional areas. We have fabulous coordinators that work with us monthly. They know us, they know our voices, they know our concerns, and we have smaller sessions so that we can get productive feedback to CMS.
All right, great. Thank you so much, Jordan, on that information regarding potential doing regional learnings with ACO coordinators, but also the information provided regarding the cost and administrative burden that you all believe, or that you believe that's being caused for new requirements to report via the APP. As we've been providing on the call today, definitely taken under advisement, and thank you very much.
Okay, and we can round out with a few comments that have just come into the chat box. These include suggestions to penalize hospital systems that would withhold communication from independent PCPs outside of their systems. Another notes that the APP is a good step towards moving to true value-based care. However, the transition away from the web interface will negatively impact ACOs, and benchmarks should be very different for MSSP ACOs, as they have the challenge of working across large and diverse populations. We do see a few that talk about delaying implementation and delaying the timeline as possible. The APP needs to be delayed at least 2 to 3 years. One commenter says, in the delay should be communicated to all ACOs in a timely manner. Another notes that if changes are going to be made for reporting in 2022, a decision should be made before August, which is the deadline to add or delete TINs, as they may have to delete or drop TINs as specialists because of new reporting rules. And finally, more encourage CMS to hold all specialties in an ACO accountable for measurement, rather than only requiring primary care to report. And finally, it would be greatly helpful if CMS could clearly outline the process of how ACOs will be audited on accuracy of data submitted and data completeness. So I know we had quite a lot of comments and feedback. So Stephen, we will pass it to you to see if there are any final thoughts before concluding.
All right, thank you very much, Lauren. We just want to thank you all again for joining us today. We definitely appreciate all of your. We definitely appreciate all of the feedback we've received. We're going to take this all back and figure out next steps. We can go to the next slide. So next, I will go ahead and turn this back over to you, Lauren.
Great, thank you. Right, just a few reminders before we go ahead and conclude. As that does wrap up our discussion today, so please note that you can contact the QPP Service Center with questions by emailing qpp@cms.hhs.gov. Alternatively, you can call 1-866-288-8292. And of course, customers who are hearing impaired may dial 711 to be connected to a TRS agent. Alternatively, you can always email the Medicare Shared Savings Program at sharedsavingsprogram@cms.hhs.gov. So we'll send those emails out as well. But with that, we will conclude today's listening session. As a reminder, the slide deck recording and transcript from today's session will be posted to the QPP webinar library within the next week. So thank you all again for joining, and have a good rest of your day.